We have 4 distinguished Missouri experts to talk about Missouri's healthcare workforce this morning. We're going to start off with Dr. Jack Caldwell, who is a distinguished faculty, has been a distinguished faculty member at the University of Missouri for a very long time, since 1964. Is that right? Okay. Okay. All right. He was associate dean at one point. He was head of family medicine from 1972 to 1977 and really was instrumental in shepherding the family and community medicine department to be one of the premier family and community medicine departments in the country. Dr. Caldwell is an expert on workforce nationally and has been recognized for this work, and I'm sure he'll talk a little bit more about that. You have all of their bios in your packet. Mary Becker is going to go next, and she is on the Missouri Hospital Association's senior management team. Mary has a very broad portfolio of activities for which she's responsible, including healthcare workforce. And I think she'll probably talk a little bit about those efforts in her comments. Third, we're going to hear from Sue Kendig, who is both a nurse practitioner and a lawyer and has been active in writing and speaking about advanced practice nurse issues and health policy for some time in our state, and we're very much eager to hear from her. And finally, I've asked Chris, our good friend and who was co-director of the center and co-founder of the center for many years before he put on his 3 other hats, to come. And Chris is Associate Dean at the School of Health Professions. He also directs the Masters in Public Health program at the University of Missouri. So I've kind of asked him to play cleanup and see what he can add. Chris was also an RWJ Health Policy Fellow in the 106th Congress, 7th Congress, okay, in the 107th Congress. So he has a broad health policy expertise and perspective on these issues. So I want to welcome the panel. If you can give them a round of applause for me, I'd appreciate it. And we'll start with Dr. Caldwell.
The topic is one of workforce. It's a topic that I have been involved in for, as you gathered, for a year or two. And it's one that is an intractable problem. I thought Harold Miller's presentation was just wonderful because what he did was he put together the framework of a discussion on re-engineering healthcare. And he points out that much of it lies with the business model, i.e. where the bucks are. And I thought as he did that, it fits very well with what I want to address here. Because we do have a conundrum in healthcare and workforce in this country, and it's been one which has been with us for a long time. As you know, we have a new law providing increased access for the citizens of this country to health care. I'd like to start off by asking you, all of you know what's going on in Massachusetts and that they have a model that's very similar to what we're in the process of implementing in the rest of the country. Where would you guess they stand in primary care in terms of the ratio of primary care physicians to population? They are number 1 in the country. And you've been hearing about all of the problems of access that have increased in Massachusetts associated with health reform. Now, I think one can't look at this purely as a numbers game. One has to look at it as a systems issue. But that gives you a little bit of an idea of where I'm starting off from, because, you know, access really does require an adequate workforce working in a high-quality system of care. Now, the Association of American Medical Colleges has been very, very concerned about an upcoming shortage in physicians, and they have, looking at what's happening to the increasing population, they're coming out and saying we face a shortage of 130,000 physicians, and they say that half of that, or 65,000, is in primary care. Now, this is from a study that my colleagues and I published in Health Affairs a few years ago, and this was looking at what future demand is likely to be, and we used as a proxy for what demand will be the projected number of visits, assuming that we continue to provide care as we have in the past for the population. And you can see that the upper line is is likely to be the situation in the future when, as our population ages, and most importantly, as it increases at over 1% per year, the numbers of visits will rise by 29%, assuming, as I say, that things continue as they are today. And you look at the lower line, and that's looking at what's happening to our physician workforce for primary care. And as you can see, that's tapering off so that we'll have, in terms of FTE physicians out there in 2025, if we stay where we're at today, roughly 2% more than what we have had. Now, Harold was commenting earlier that this is an issue that is going to need to be a fundamental piece of any re-engineering of our healthcare system. Now, interestingly, as you might guess, we aren't facing a major shortage in care of children. What I was showing you before was this is generalist for care of adults. For children, the issues are really that our birth rate hasn't gone up that much, and so the numbers of kids are only projected to go up about 12%, and the numbers of pediatricians and family physicians doing child care will be going up roughly that amount. Well, our studies suggest that we will have a shortage of 50,000 family physicians and general internists by 2025. And that's assuming we continue to practice as we do today. Now, 50,000, when you look at Boone County, that's a third of the total population of this county is a shortage just of family physicians and general internists. Makes you think a little bit that this is a thing of potential real magnitude. If we were to try to solve this with adding numbers of docs, that would require roughly 9,800 family physicians and general internists graduating annually, and today we have about 5,800. So we'd need to come close to doubling our output in order to continue to practice as we do today. And I'd like to point out here that as I'm talking about family medicine and general internal medicine, I'm also want it understood that healthcare is a team endeavor, and more the issues around physician assistants and nurse practitioners need to be considered as a part of this because their shortages are proportionately the same. Now, what we face in medicine in primary care is that we've had a shortage of both applicants and of residency positions. And the numbers have been going down. They've now leveled off and may be beginning to increase. And I think Harold pretty clearly pointed out earlier that we live in a system that is inefficient, it's fragmented, costly, and that changing that system is a part of what we're all about right now, and you don't change systems overnight. And he pointed out that I think some of the really exciting things for those of us in primary care are the potentials that are out there of implementing an approach to health care called the patient-centered medical home, which many of you have already been hearing a lot about this. And that would be the foundation of an overall system of primary care, which includes the rest of our health care system, and through shared savings, accountable care organizations hopefully being able then to create more efficiency in health care delivery at the same time as it reduces hospital admissions. Now, what we've seen over the years is a lot of hospital beds filled, and I think our earlier residents, like I can remember, I spent a significant part of my time preaching to our residents that our role, that if we admitted a patient to a hospital, it was a sign of our failure, and we've certainly failed miserably. Well, where are signs of progress thus far? The AAMC is going to achieve its goal of increasing the overall medical graduates by about 30%, and that'll be there by roughly 2015. We've added 8 new medical schools and 9 new osteopathic schools. Virtually every medical school in the country has increased class size. But if you think back and realize that today's system and today's world, only about 17% of those are likely to go into primary care. So this big increase in medical class size may not have much impact on primary care. And, you know, there was David Goodman from Dartmouth presented before the Senate, one of the Senate committees, I think it was the Finance Committee. He argues very strongly, as do others, that perhaps it's not just more doctors that we need, but it's doctors in specific areas of shortage that we need. Now, another good thing that's happened this year, I believe, is that the Council on Graduate Medical Education has come out with a recommendation that the overall proportion of physicians that are primary care docs be increased to 40%. It's currently at roughly 32% and going down. There is, as I suggested earlier, some suggestion that medical students' interest is increasing, and I think at least a part of that is due to the fact that discussions of the medical home are quite attractive to many medical students today. The differences in income between primary care physicians and specialty physicians is also maybe, there are things that are happening that suggest that's going to get reduced. You know, in the last decade especially, the system that we have for reimbursing physicians has resulted in an increasing discrepancy between the income of specialists and those of generalists. And in the Accountable Care Act, they've built in a 10% increase for primary care in regular reimbursement. MedPAC has come out with recommendations for looking at how we address the tremendous budget problem that we have. And they've come out with recommendations on what to do about physician income. And this is not leaving many physicians enthusiastic at all, but it's saying that we should freeze primary care income at the same time that for each of the next 3 years, specialists should have a 6 or a 5.9% drop in income. And all of this would be as the SGR is replaced, is eliminated. So this will be hitting the press more and more, these discussions, and I think, as Harold said, that there will not be happy physicians in the group, but on the other hand, the discrepancies, which I think have been one of the major things in income between specialists and primary care, may be reduced, and this, as it happens, I think will have a positive impact on increasing the numbers there. And then very positive is, I think, the movement towards supporting a medical home. And these are coming in fits and starts and around specific examples, like as he was mentioning the group health activities in Seattle. And we're getting increased funding in primary care to expand what we're doing and do what we should have been doing all along, trying to keep people out of the hospitals through much more proactive care management and much more emphasis on prevention. A huge block that's standing out there is that we have a freeze on the funding of graduate medical education positions. You may not know, but most of the funding of residency education in all of the specialties comes through Medicare. And obviously, this is one of the things that is at least partially on the block. The salaries of residents, the Medicare, about 100,000 are covered by Medicare. And there are suggestions that this will be cut back significantly. If that does happen, it's also quite likely that we will not see the needed funding for expanding of primary care physicians. So, huge issue sitting out there, and you're going to be hearing more and more about it. The other roadblocks which are out there and have been the huge student debts. Average medical student graduates now with a debt of about $155,000. That's big even for those of us that have been out for 30 years. We have institutional cultures that have not really supported primary care to a great degree. One of the great joys of my career is having been here at University of Missouri, where the institution has always been a strong supporter of primary care, and that's done much for us to be able to assist the state. Upcoming budgets that are already being considered for next year by the Congress are eliminating funding of Title VII programs, which support expanding residency programs, amongst other things. The likelihood of decreased funding of GME I've mentioned in another context. And you know, one of the things that was in the Accountable Care Act was really a desire to move toward a more rational workforce. And so a part of what was there was a National Workforce Commission. Thus far, the Congress has not appropriated a penny for it, and so it has met once by telephone, and its impact is going to be contained, I'm afraid. So let me stop by just pointing out a statement by Tom Daschle when he was up for confirmation for Secretary of Health and Human Services. He showed this slide, and this triangle here shows what the system of primary care that's present in most other countries. Strong primary care base. And this here is his description of primary care in this country. And his statement was, quote, "Every other country starts at the base of the pyramid with primary care, and they work their way up until the money runs out. We start at the top of the pyramid, and we work our way down until the money runs out." And so we have to change the pyramid. We have to start at the base. And I think that is one of the basic principles that as we re-engineer our healthcare system that we look to in the future in addressing the workforce issues. Thank you.
Please, if you have questions, write them down because we're going to take all the questions at the end of the panel presentations. So, Mary, you're up next.
Dr. Colwell's remarks were just a great segue into some of the things that I'm going to talk about, and of course that's how panels are supposed to work. They don't always work that way, but it did work very well. I'm going to really talk about the healthcare workforce and the issues on a broad scale from the hospital perspective and some of the issues that we're looking at. As you've heard, we're preparing for increased demand of healthcare services, the aging population, the implementation of the health reform law, and we have a system that is already strained. It's difficult to get an appointment with physicians in many parts of the state. And the healthcare reform law, we're estimating, will increase access for those that are previously uninsured, and we're estimating about 500,000 additional Missourians will be insured beginning in 2014. So the issues that we're looking at related to all the new opportunities for coverage through expanded Medicaid, through the health insurance exchanges, those 500,000 people, are enrollment. In order to get the individuals covered, we're going to have to worry about how we're going to be enrolling them. And that's one of the things that we're beginning to focus on is how do we make sure that hospitals and physicians and clinics and schools are reaching out to enroll newly eligible individuals. We also are going to be facing health issues with this population. We're anticipating a large number of adults to be newly enrolled. And many of these are adults who haven't had coverage for many years in the state of Missouri in particular. And so, what are their health issues going to be, and how much are they going to need to access the system from in those first few years? They're likely to have some very chronic health conditions that have been ignored. And then, again, touching on the access issue, where are they going to get the care? Do we have enough primary care physicians and nurse practitioners? Do we have enough individuals to care for them? And so if you look at the changes in coverage that we're anticipating under the reform law, and this would just be the population under age 65, and looking at about 2016, the column on the left is prior to the law, and then the new law, which would be about, leave about 21 million versus 53 million uninsured. 22 we're expecting to be enrolled under the new health insurance exchanges. 51 million under Medicaid and SCHIP. And then employer coverage will decline. It's being anticipated it will decline slightly to 162. So you can see those changes there. And then when we look at the MoHealthNet, our Medicaid program enrollee growth, when you look at the current situation, we have a large percentage of pregnant women and custodial parents, large percent of children, and then the persons with disabilities. And a lot of that is due, and we talked about the large number of adults who do not have insurance coverage, and that is largely due to the reduction in the income guidelines that was implemented several years ago. So you can see that parents have to be at 18% of federal poverty to be eligible. And then disabled individuals at 85% of federal poverty, and Missourians age 65 and older at 85% of federal poverty. Only two categories, blind and qualified Medicare beneficiaries, are eligible at 100% of federal poverty. So this is where that large number of adults we're anticipating. And then if you look at the future, what you've seen, what we can see on the chart, what Missouri Health Net enrollment has done over the years. So if you look back to 2001, we had a peak of 100,000, or a million, I'm sorry, in 2005, and then that has declined pretty dramatically over the years. And then, but what we're anticipating moving forward is an increase. It's going to remain pretty much steady state until we get to 2014, and then we're going to see a huge spike in the number of individuals covered under Mo Health Net, so up to 1.2 million. So with all that in mind, then we have to look at what the health of our state is. And unfortunately, it's not good. We rank 39th in overall health rankings. We're down from 2009. We have a high prevalence of smoking. Our health policies in the state of Missouri do not incentivize lower rates of smoking. We have about 25% of our population that smokes, and we have the lowest tobacco tax in the state. There's going to be another third round of increasing that tax, an initiative that is just getting started again. And then we have a low per capita public health funding. We have low immunization coverage. We're not giving our children vaccinations at a very high rate. We have a very high rate of preventable hospitalizations, and we are the 12th most obese state. And those aren't pretty things. Now, apparently, we do have good knees, from what I heard earlier, so there's some good news in this picture. But so now, from going back, kind of pulling back, looking at all these things from the hospital perspective, we look at the trends and what are we facing, and what are the trends that we're looking at and grappling with all of these other things going on in the state. One is job growth. We've had a huge number of jobs that have been added to the hospital world and really in the healthcare sector in the state. A shift in service delivery that's been going on for 20 years, and then a shift in payment incentives. So I'm going to talk about a couple of those things. When we look at job growth, it's been one of the bright spots in the economy, if you can look at it from that perspective. That in 2010, we employed 14,000 more people in Missouri hospitals than in 2009. There is increased demand for those jobs, and we're having more people retire. We have an older healthcare workforce. The high-growth hospital jobs that we're focused on right now, obviously RNs, that's about 60% of our healthcare workforce is registered nurses, so we're always focused on that population. HIT, with all the changes and the requirements that are going to be needed, both in electronic health records and in patient tracking and all of that, we're looking at huge demand there. The therapies, which is obviously gets to some of that post-acute care. Radiologic technology, so the imaging, pharmacists, and then lots of aides and techs, and lots of interesting programs that have been undertaken throughout the state, focusing on how do we retain people at that entry level, how do we encourage them to enter at that level, and then show them the healthcare pipeline that's available to them once they get their foot in the door. Obviously, this has been the growth in outpatient visits over the last any number of years has continued. It's been up nearly 2 million since 2006 in the state of Missouri. Our inpatient visits really have remained relatively flat. They were just down 12,000 since 2006. But our inpatients that we're seeing are older and sicker. They are having shorter hospital stays. So the acuity and the environment that under which they're being treated makes a huge demand on our healthcare workforce. So we have to really think about the types of people that are caring for our patients. And then our payment incentives, as you've heard earlier, they are moving they're shifting to improvements in quality and prevention and penalties for poor outcomes. So we're having to shift the way we think about treating patients and come up with new models of care. And I'm going to focus now on really what the issues are in rural Missouri. And this is pretty much focused on a report that we produced about the primary care physician workforce in rural Missouri. And it was spurred because we kept hearing from our rural hospitals that I have 2 physicians, and one is over age 60 and the other one's over age 70. And I don't have any prospects for new ones coming in. So we wanted to kind of get a sense of what were the disparities in the rural physician workforce in Missouri. And so to look at that, really wanted to look at what does rural Missouri look like. Our rural residents are older. Average, if you look at the comparisons between rural and metropolitan Missouri, about 3 years older on average, and a larger percentage of elderly, 65 and older. Rural residents are poorer. We have about 19.5% uninsured compared to 15.5% in metropolitan. I won't go through all of these. You can also see the disparity in the median income of about $12,000, and then the literacy rate in rural versus urban Missouri. Then we look at our health status. Again, I've touched on that already, but when we look at the percent of those who smoke, those who are obese, now that's the same in both rural and metropolitan Missouri. But our cancer hospitalizations, everything is just slightly higher in rural Missouri. And then when you look at our ratio of residents to primary care physicians, that's a huge disparity. 1,700 primary care physicians for every one in rural Missouri, and 962 residents for every one in metropolitan Missouri. Now we look at our physician characteristics in rural Missouri. Those were population. Our rural primary care physicians are older. If you look at, again, the comparisons of all licensed physicians, but then look at our average age, you can see that there is a huge difference in the average age and the percent that are older. And so then when we look at what are the other compounding issues in rural Missouri, our rural physicians work longer hours. From research that's been conducted, the incomes are approximately 5% less than their urban counterparts. They tend to work longer hours. They see more patients, they work longer hours, and then they see more Medicaid patients. And again, because of the poverty that you've seen in those parts of Missouri, you're seeing that that's probably a compelling reason. So how is this affecting our rural communities? It will, with access to health care, obviously, which is going to lead to those poorer health outcomes. So you're seeing how this is all playing out in the health of the population. And then economic impact. We're all struggling with the economy and the economic downturn, and one primary care physician in a rural area generates over $1 million in annual revenue and creates 23 jobs. So there's a real incentive to bring rural physicians to our rural communities. And I won't touch on much of this because Dr. Colwell has already pretty much touched on this. But the large debt, the things that are contributing to these shortages, large debt, the disparity in salary, the increasing number of female physicians that have different lifestyle and social issues and reasons that they don't choose practice in rural communities. Then poverty and lack of medical insurance. You know, the rural communities have the highest poverty rates. It's less attractive to practice in those communities. And then what can we do to change that? And there's a lot going on. Studies have shown that medical students are most likely to practice in rural areas, that came from rural areas. And medical schools are creating wonderfully creative solutions. The University of Missouri is a prime example of their rural health track and what they're doing to create incentives for rural healthcare practice. And then, again, Dr. Colwell touched on the teaching hospitals and the residency slots. So I'll leave it there.
Morning. Well, these actually seem to dovetail really well, so what I hope to do is present the nursing view in the next 10 minutes or so. And as Karen said, I'm a nurse practitioner, which means I'm a primary care provider. I'm also an attorney, and in my legal and policy practice, I work with providers and health-related entities in doing strategic planning for the development of ACOs, medical homes, and other clinical integration models. So essentially, I am living both sides of the coin we're talking about today, and it's really an exciting place to be. What I hope to do is frame for you what nursing brings to the table in terms of helping us move forward in a new direction to meet the triple aim of better care for individuals, better health for population, and improved efficiencies in our care. And I'd also like to talk a little bit about the barriers and some of the issues that arise where we may not be utilized to the fullest extent where we can impact some of these outcomes. As you know, we have several barriers to improving the triple aim. And, we all talk about the triple aim as being something new. I've been in healthcare for 35 years, and for 35 years, I have been trying to provide better care for individuals, better health for populations in a more cost-effective manner. The difference is now is that it's getting wide attention, and we have technologies to scale some of the applications that have been performed earlier under demonstration projects and so forth. When we look at removing the barriers, essentially what we need to do is fix our perverse payment system, and we've heard a lot about that this morning. And we're doing that by looking at incentivizing quality and cost efficiencies. So essentially, for practices to make money, they're going to have to meet and exceed certain benchmarks. I would posit that the skill sets that one needs to do that are things like care coordination, helping patients and families navigate care transitions to be more efficient in their access to care and how they utilize it, case management strategies, health literacy strategies, and certainly we hear a lot about patient-centeredness. What that means is helping patients and families integrate the prescribed medical regimen to the reality of their patients' lives. And I would invite you to consider that those are all nursing skill sets, and nurses are a vital component of success in moving that marker in improving quality and cost efficiencies. So, what do we need to do in order to make that happen? Well, first we need more of us. Just to give you an idea, and this is from Missouri data, by 2014, it's expected that we're going to need 23,000 more nurses to meet the needs in our state. That's a 20% increase over the past decade in what we've needed to have. Right now, according to Missouri Hospital Association data, the nurse vacancy rate has stabilized at around 5% across the state, and the turnover rate is about 15%. It's costing us a lot of money. In 2010, that cost over $364 million to pay for RN turnover across the state in hospitals. So it is a significant issue. The other issue, and Mr. Miller touched on that this morning when he talked about care moving from hospitals into primary care, and yet most of our workforce is working in a hospital setting. What does that mean? Even if we had enough nurses, we need to look at retooling them to help people understand what it means to work in primary care, to support what it means to do home visits. You know, back in the day, 30 years ago, 35 years ago, when I was in my diploma program in rural Pennsylvania, We learned really quickly, if you took care of the patient in the hospital, you got a C. If you took care of the patient in the hospital and you hooked him up with some community resources, you got a B. If you took care of the patient in the hospital, hooked him up with community resources, and did home visits, you got an A. And I liked A's. So home visits are my very favorite thing. We need to look at reintegrating those types of skills into our nursing education program because we have moved a bit away from that. And in fact, last week I was in Washington, D.C., presenting to the Board of Directors of the American Associations of Colleges of Nursing, so essentially the Dean's Group, on this very issue. They asked me to come in and talk about ACOs and what types of skill sets we need to look at in nursing education, not only for nurse practitioners, but for our baccalaureate prepared nurses, so that we will have those skill sets to put people on the ground in primary care, in public health, and doing home visits in home health facilities and home health agencies so that we can actually help to move the markers we're talking about. The second issue, and I'm going to spend more time talking about this, is increasing our primary care workforce using advanced practice registered nurses. And we know that one of the issues are how we operationalize allowing full scope of practice. And we're starting to get national attention in that regard. The Institute of Medicine last year issued a report on the future of nursing. And one of the key recommendations was that nurses should practice to the full extent of their education and training. What does that mean? That means if I have been educated to do it, it is when the scope of my practice of my particular specialty, in my case, women's health. So I've been educated to do it. I've been educated to do it within my role, and I am legally allowed to do it. I should be able to practice to the full scope. And we know that across the country and in Missouri, there are some barriers, probably because some of our rules and regulations were written over 20 years ago where we didn't have some of the technologies and capacities and needs that we have today. So looking at how we facilitate that top of the license or full scope of practice to help increase our primary care workforce. The other thing, going back to that top of the license issue before I go on to collaboration, Dr. Caldwell and Ms. Becker both talked about the shortage of primary care physicians. In Missouri, we have about one primary care physician per every 1,776 citizens. In urban areas, that's one primary care physician per every 962 citizens. So in rural areas, we have fewer physicians serving more people, and they're older. Most of them are over 60. Now, when we talk about advanced practice nursing being a solution to the primary care shortage, on one hand, that is possible. In the state of Missouri, we have over 4,000 advanced practice registered nurses. However, only 775 of them practice in rural areas, and yet we are an 80% rural state. So even if this was the magic bullet, they aren't in the rural areas. And there are a couple of policy issues around that that are different than there are for physicians. Advanced practice registered nurses obtain a graduate degree. So we are registered nurses, and most of the programs require that our students coming into the graduate program have at least 2 years of experience. So we're talking about people who have families. They have a very difficult time leaving the rural area to go to Kansas City, St. Louis, or Columbia for their programming. So looking at different ways of delivering education in those rural areas where people can actually access the education is an important component. The other issue is, how am I going to get them preceptors? I don't have enough primary care providers to take care of the patients, let alone to start getting preceptors. So even if we get really creative with telehealth and webinars and all that kind of stuff, they still have to have time on the ground in primary care. We don't have the preceptors. The other issue with that, you're talking about decreased GME money. We don't get any GME money. So not only do I not have people to precept my students, but I can't pay anybody who does. It is very difficult to get preceptors. The Patient Protection and Affordable Care Act put some model programs in looking at making monies available. to support precepting for advanced practice registered nurses. They had 8 pilot projects. The money went to hospitals, which is wonderful, except for the most part, hospitals don't educate primary care advanced practice registered nurses. So we have some disconnects in how we can educate the workforce of tomorrow, particularly in meeting these high needs in these high shortage areas. The other issue that comes up is the top of the working at the top of your license issue. And when I speak with my physician colleagues who are concerned about how this is all going to evolve in terms of what advanced practice nurses can and can't do, sometimes I think there is a little bit of confusion regarding what is collaboration versus what is a collaborative practice agreement. Collaborative practice or collaboration means that we all play well together. We all talk to each other. We are working as a team. And I would invite you to consider that there is a body of evidence emerging right now in the literature that suggests we don't. Just because you have a physician, a nurse practitioner, maybe a med tech, maybe an RN in the same place doesn't mean you have a team. That means that you have 4 people working in the same place. And patients know it. And patients are saying some of the reasons we're not getting the good quality outcomes and efficiencies is because we don't work as a seamless team. And we work as individuals and we don't share the information about the patient and collaborate. A collaborative practice agreement by law is a written agreement. The definition I have up there is what it says in our Missouri collaborative practice rules. Having it written down doesn't guarantee that you are going to operationalize the type of team-based approach that's needed to meet these markers. So I think that's the first thing to consider. The presence or absence of a collaborative practice agreement doesn't mean that we are truly collaborating. Therefore, if there is not a piece of paper, that doesn't necessarily mean collaboration is going to stop, and I think that is a very important point for us to remember. The other issue that comes up when I speak to my physician colleagues is around scope of practice issues, because they will say, well, I don't think advanced practice nurses should be independent, autonomous, whatever, because I sent a patient back to my physician colleague and I didn't know, but they were seeing a nurse practitioner and something happened that I didn't like. And my response is, that is a scope of practice issue, and that is a collaboration issue, because these people already have the collaboration agreement. Therefore, there was a disconnect somewhere, and that's what we need to work on, those disconnects, because the disconnects are where the sharp edge, where inefficiencies and potential harm can occur. So I would invite you to consider that rather than focusing on a piece of paper, we focus on our team building and communication. When we look at collaborative practice across the country, there are varying levels of requiring some type of written agreement. And this map just tells you in 28 states there's no requirement for physician involvement in the diagnosis and treatment. However, we see that in 35 states, so in more states, they do require a written agreement for prescriptive authority. And if you look at this map, this tells you that the red states, there is no requirement for any kind of written agreement. In the light blue states, it's a requirement for prescription only, and in the dark blue states, which includes Missouri, we have to have the written agreement for diagnosis, prescription, and treatment, delegated medical acts, according to Missouri law. So in about 26 states, there are more restrictive rules around what needs to be in writing. And again, that doesn't necessarily mean there is a cohesive team doing this, but there is a written agreement. So when we talk about Missouri specifically, I think we need to look at what are some of the rules and regulations other than the issues that I talked about regarding educating our workforce to support the primary care workforce, but also what do our collaborative practice rules say that may need to be looked at in terms of barriers. Number one, geographic restrictions. These are direct road miles, most direct route. If you are in a healthcare provider shortage area, my collaborating physician must be within 50 miles. If I'm in a non-HPSA area, my collaborating physician must be within 30 miles. Think about that and the implications for telehealth, because now I could have the potential to be seeing patients and have even more direct access to my physician than somebody who's 50 road miles away, but I can't have a collaborative practice agreement with them, and I can't take advantage of that technology. Likewise, think about the provider shortage. If we have so few primary care physicians in these remote rural areas, and there are restrictions on how many advanced practice nurses they can have a collaborative practice agreement with, I have a limited ability to actually leverage my workforce. There is a requirement that we practice together with our collaborating physician continuously for 1 month when we start working with them, which in some cases may be appropriate, but if I am an experienced advanced practice nurse, my physician moves away, I get a new physician. Now I'm tying up 2 providers who know what they're doing to meet this rule. So how many patients are not being seen? It's burdensome to the practice, it's inefficient from a cost perspective, and it is burdensome to patients. It decreases their access. There is a requirement that the physician must evaluate new patients or those with significant changes within 2 weeks of them being seen by an advanced practice nurse, and that is for patients who do not have acute or self-limiting problems. So these are the patients in a practice who come in, it's a new patient, or it's my hypertensive that has all of a sudden developed something new and exciting. Number one, now I've increased the burden on my patients because I have to say, okay, you've got to come back within 2 weeks to see the physician. Patient doesn't do that. Now what do I do? Because I'm running afoul of the regulations. And also, is that 2-week time frame really reasonable? Is it better to have the type of direct access we're talking about in terms of telehealth? And quite frankly, in my practice, my physicians have always been readily available. You can pick up the phone and ask those questions. So is that a necessary rule, or is it unduly cumbersome? There's a documentation review rule, my favorite. Listen to this. Every 14 days, the physician must review 10% of the care provided by the nurse practitioner, unless they prescribe controlled substances, in which case 20% of the charts that you have prescribed controlled drugs for have to be reviewed within that 10%. So you essentially need somebody to be pulling these charts. There are practices that have actually done time work studies and looked at the amount of patients and money that have been spent just meeting that one rule. And the final rule, that there are a lot of them, these were the top 5 that seemed to be barriers, was the physician presence on site every 2 weeks. There's a requirement that every 2 weeks the physician must show up on site where the nurse practitioner is to provide consultation and supervision, which is fine, except if they're not there during the other time frames and there's nothing magic about the 2 weeks. That's the issue. There's nothing magic. And if you have physicians already stretched, the burden is really on the physicians and their time. So that gives you a very quick overview about some of the nursing as well as the advanced practice nursing workforce issues facing our state as we try to work together to improve care, improve health, and decrease cost. Thanks, Karen.
I'm so thankful that Karen invited me back to speak today. It's great to be talking to students, colleagues, friends, bosses. Well, maybe not so much bosses, but I'm a little nervous because I'm going to do this without a PowerPoint, and the last time that I spoke without slides was when we didn't have PowerPoint. So we'll see how this goes. My purpose this morning is to extend the issues that have been discussed and make some additional recommendations. The nice thing about going last on a panel is that if I make outrageous statements and start a food fight, at least the other panelists have had their opportunity to speak, and we'll have time to clean up the room. So, oppressive political regimes often imprison their dissenters, especially those dissenters who have liberal democratic ideas about equality and sharing resources. The oppressors go to great lengths to quiet their distractors, primarily out of fear. fear of loss of power, fear of loss of wealth. So in response, what we hear often is a call for the release of these prisoners. It goes something like, free so-and-so. So this morning, I'm calling for us to make those calls. Free the nurse practitioners. Free the physician's assistants. Free the nurse anesthetists. Free the dental hygienists. Free the public health professionals, right, Linnell? Free the psychologists who seek prescription privileges. Free the physical therapists who want independent practice. And free the pharmacists. Okay, no food so far. All right, so we'll keep going. It's time that we allow these professionals to practice at the full extent of their education, as was previously stated, and the highest level of their skill. Those who want to prohibit this through Practice Act provisions are doing so out of fear. Now, maybe it's a compassionate concern about the welfare of those who are sick or injured. Or maybe it's not so compassionate and it's a fear about loss of compensation or loss of power and wealth. Regardless, those fears are not reality. There is overwhelming evidence that practice models, rural states, and other programs show that these professionals can practice and deliver very high quality care that's safe, and frequently, and no one wants to hear this, they have higher patient satisfaction ratings. There is no credible evidence that these patients are being harmed by our nurse practitioners or physician assistants or others. On the contrary, the health and well-being of the public is enhanced. Now, what happens when I say these things, these outrageous remarks, is I'll go outside and then someone will approach me with a story about someone who is harmed. And the narrative typically goes like this. It's something along the lines of, my third cousin Jason's friend Susan, well, her brother John had a son named Billy who went to the nurse practitioner and was misdiagnosed, pneumonia was misdiagnosed, and he missed 2 months of school, and he ended up running off to the circus. That's not credible evidence. I talk to my students all the time about looking at what the evidence is telling us. We've seen in the rural and frontier states that they have set non-restrictive scope of practice acts for their nurse practitioners and their physician assistants, and what they found is better access to high-quality care. It's been shown time and time again. The other thing that I hear often when I make these outrageous statements is that, well, if they wanted to be doctors, they should have gone to medical school. Right? You've heard that before, right? I heard some laughing. They don't want to be doctors. That's why they didn't go to medical school. There we go. Now we're getting it fired up. I'm in so much trouble. They want to practice within what they learned how to do, and they want to use their best skills. So let's let them do that. The beauty of this solution is that we're going to have healthcare practitioners of all kinds practicing to the highest level of their skill, including our primary care physicians and other physicians. They'll have the opportunity not to have a patient panel of 2,000 people, but a patient panel of 600 or 800, and then they can do the best that they can do for their patients. They can practice at the highest level of their skill too. Now the sad part about this, although maybe it's not so sad, there's really plenty of work to go around. We're not limiting the amount of health care we can provide. Remember that pretty soon we're going to have 30 more million people insured in this country through the Affordable Care Act, and we're going to have 70 million baby boomers. Now some of you are in this generation. I'm at the tail end. And we don't know what it's going to be like to deliver care to these baby boomers. They just started retiring, right? But what we suspect is they're going to demand a level of care that's different than what the previous generations have demanded. I'm pretty sure that I want to keep running when I'm 75 or 80 or 85 years old, so I'm going to expect those knee replacements, and I'm going to expect to stay healthy that whole time. If my knee creaks, I don't want it to creak anymore. I'm going to go have it taken care of. So we're going to have a lot of people with chronic illnesses that are living for a long time and a lot of demand for services. So it's not like we have limited wealth. Now, we've got to deliver that care in a more efficient manner, and this does, right? So we have people that aren't paid as much, and so we're spending our health care dollars more efficiently. Frankly, if you're in health care, your goal shouldn't be to live in the suburbs and make $400,000 a year. And that's what we're seeing too often right now. So 3 broad solutions, and then I'll have some specific solutions that I stole from another group, and I'll give credit to them in just a minute. The first is that we stop the restrictions on our practice acts for our non-physician providers, and we give consideration to even extending those acts. So Kansas recently has proposed a new professional, registered dental provider who would do very basic dental skills like tooth extraction, basic filling, some cleaning. It's a step above the dental hygienist, a step below the dentist. It's a really interesting idea to provide dental care in rural Kansas in particular. Now, the Kansas Dental Association has opposed it, but these are the kinds of things that we're going to see in the future, where we have different levels of care and people who are trained to do that. The second thing that we need to do, especially in Missouri, is to have an effective registry so we can track our providers and where they're practicing and how much. And we started to do that with now I got to get this right, it's the Missouri Healthcare Workforce Registry Exchange. Okay. The state has done this, and it's very commendable. They lose a point for the really silly acronym, but they gain a lot of points because finally we're going to start to get really good practice information about many of our professionals in this state. The group that's not in there yet, well, several groups that are not in there, the key groups that are not in that exchange will be the nurses and the licensed professional nurses. We need to include those sometime in the future. The good thing about this new registry is that they're going to be able to make this open to researchers and others who can track this data, follow it, do analyses, and then we will know in the future where we need the professionals and how many of them that we need. And this goes to my third point, and that is we need also 2 things in Missouri. One, we need greater funding for higher education, and I just meant generally for higher education. I think we're last in the nation now in funding for higher education, and that's really a sad place to be. And then extending from that, we need greater funding for health professional education. A few years ago, you remember, I think 2008, our president at the University of Missouri put together a team to go out and reach out to all the 2-year and 4-year colleges to develop Missouri Cares, and we did this. It was a tremendously collaborative initiative. All the 2-year colleges, all the 4-year colleges that had health professionals came together and said, we can put out more practitioners in all these areas that you need, including dentists and dental hygienists and various kinds of nurses and speech pathologists and physical therapists and occupational therapists and physicians. And we got the governor and the legislators to fund it to $38 million. And that goes over a course of about 2.5 years. And it's worked. We have many more professionals along those lines. Of course, then the recession hit, and so that program didn't get extended past that 1 year. So at least we have a little bolus to get started, and it serves as a model to show us that if we fund this, we can get practitioners to be trained in Missouri and to stay in Missouri. The workforce tracking data that we have, especially of the nurses, shows that if we train them in a local area, they stay there. They stay there and they live there and they work there. So what a tremendous boost to the state of Missouri. Okay, so then some other solutions, and I'm going to try and make amends with the physicians now, at least the primary care physicians, and that is we've got to, and this isn't anything that we can do except to put pressure on our Congress, and that is they've got to modify the the resource-based relative value scale so that there's not so much disparity in payment between primary care physicians and the specialist. That's really going to be important. And some of these solutions, by the way, are from a recent Robert Wood Johnson synthesis report by Catherine Dower and Ed O'Neill. Some of you recognize Ed O'Neill's name. It's on primary care. The second thing we can do in the very specific area is to extend eligibility for payment for extenders who work in physician's office. So we can have community health workers go out and monitor and track people with chronic diseases, make sure they're following their treatment regimens, taking care of themselves, and then the provider team can get paid for that. The third is we need continued support and expansion of the community health centers, the federally qualified health centers. I know we have Joe Perley speaking later on. Karen and I remember that in 2000, the funding for federally qualified health centers from Congress was about $125 million. And we were successful in helping to move that forward to $175 million in the subsequent years. And now it's going to be $11 billion over 10 years for federally qualified health centers through the Affordable Care Act. It's a tremendous boost, and we have to continue to fund them because they are key to delivering primary care, especially in rural areas, and we've just got to continue to support them. Now, a little more heretical statements. We also have to extend and expand and evaluate our retail primary care clinics, those retail clinics in the stores. They deliver care where people are. People go to Walmart, they go to Walgreens, they go to Target, they go to other places. So let's think about how that can be an effective avenue for us to deliver primary care. We need to expand telehealth, and Karen may want to speak to this later, but we've got to figure out the payment mechanism so people can get the care that they need in a convenient fashion. And then finally, we need to increase the incentives and access for our underrepresented groups in our healthcare professionals. Race, ethnicity, LGBT, whatever you name. We're so underrepresented in our healthcare workforce in those areas that we've got to do something dramatic and effective about that. So I'm going to stop there with these outrageous statements, and we'll open it up for questions and discussions. And I thank you.
Well, I thought that was a great panel overall. So could we just give them all a round of applause? We actually have a few minutes for questions. Oh, come on.
Is it okay? Oh, there we go. I'm Representative Donna Lichtenegger, and I am a registered dental hygienist, and I'm very proud of it. And we are about to tackle exactly what you're talking about. And what I need is for the doctors in the room who really appreciate their nurse practitioners to please talk to your dentist. Thank you.
Interesting. Any other comments, Susan? Oh, Mom?
Yes.
Oh,
Am I on?
I think so. Uh-huh.
I am a nurse practitioner, and I love you, Chris.
Okay, over here. Yeah.
Is this on? I'm Simon McKeown. I'm a family physician. I have a question for Chris. You used the expression community health worker. Is there a program for educating community health workers in the state of Missouri, and is there any kind of licensing for them?
I don't know. I think the answer to that would
I think the answer is no. It was kind of a leading question.
Yeah. No.
Like, what are you going to do about it? That was really what I was saying.
Well, fair enough. You know, if I throw it out there, I've got to take it too. I know there are community health workers in Missouri. I don't know of any particular programs, and I'm pretty sure that there's no licensure for them. And maybe we don't want licensure for them in particular. Maybe we do. But I'd love to hear the thoughts of others.
Can I say something about
Please.
that? I always say there's three major new workforce areas in healthcare in the future. One is obviously health information technology. We're going to need a whole army of those people in the future. Another one is, this is a little more complex, but we have a very diverse society, and we heard earlier about a lot of the cultural issues, a lot of the social determinants of health, what people believe, what stories they pass down through their families, whom they trust, what are all the drivers of healthcare in terms of, and we're going to hear more about that actually at lunch. But I really think we're going to need an army of people to help us understand the populations that we serve, to go out and really do that kind of targeted focus group research to say, what do you want your healthcare providers to know about you? So that's a whole opportunity for health services researchers, actually, in healthcare that I think is untapped and will be needed. And the third thing is this community health worker issue. You know, why do we send people into patients' homes at the very beginning of life and at the very end of life? when one of the places we really need community health workers is in the middle of life when people are dealing with all of their chronic diseases.
Sue suggested that this should be a nursing issue, and I agree that that's one of the qualities that nurses certainly have is to be interested in the whole patient. Sue suggested that this was a nursing issue, and I agree that nurses could do this. I suppose physicians could do it. But are we the appropriate person? Are we properly educated to do that? I was actually looking in my practice, thinking that a community health worker would be a very useful person to have in my practice, and that's when I found that there was no education program in the state of Missouri. For one, there's no licensing in the state of Missouri. It's a very hard thing to define. And that's where I wanted to put you on the spot.
Karen, I can take that.
Well, it's a call to action. And thanks.
I could address that a little bit, I think, if this is on. And you're absolutely right. I think what you're saying goes to that top of the license issue. Why are you paying an RN or a physician to do the types of thing that a community health worker can be educated for? I can tell you, because my background is in public health, and, probably the best models we have for community health workers are those that have been written into demonstration projects. My background is in maternal child health. We've used them in maternal child health for years and years. So those programs tended to have educational programs, and I think there are models out there to look at. But also, many universities now are looking at developing bachelor's level sort of public health programming, where, again, you're talking about a top of the license issue, but perhaps people who can start to help to educate and manage and collaborate with community health workers to get to where you're suggesting.
And Karen, can I'm Belinda Heinrichs, and I'm the interim section administrator for Missouri Department of Health and Senior Services, Health Promotion, and Chronic Disease Prevention. And we're looking at community health workers in our efforts as we collaborate with the FQHCs in the state. And what we're looking at is a layperson that can be assigned to that individual. The Centers for Disease Control does have, I think, guidelines for curriculum that can be used. We're looking into that. They're a non-licensed individual, and so there is no effort at this point to promote any kind of licensure with them. But they would not be performing healthcare activities in the sense that we think of as nursing procedures or medical procedures or things along those lines. So they would be someone who could work out of that clinic setting and help patients with giving them information, connecting them with resources, those kinds of things. Would not necessarily be making home visits. So.
Chris, do you want to say
So one last comment on that. You inspired me. I have an idea. One of the fastest growing undergraduate majors in this nation is in healthcare, health sciences in particular. We wrote a program at the university to offer a Bachelor of Health Sciences degree, and we're 3 years into it now. We expected about 250 students at the end of 3 years. We have about 800 students after the end of 3 years. And not all of those people are going to end up being healthcare professionals. And so that may be an avenue where we can link this interest as well as the need and produce people to have good paying, high quality jobs that really offers a service to their community.
Susan, did you have something?
Susan Hink with Missouri Health Advocacy Alliance. I'd like for you to talk more about what the different organizations in the state have been done about collecting data about different professions of the workforce. And I also have a request for those folks. I think we also need to collect information about where the workers are living, because providers will drive more than an hour and drive by 2 or 3 rural clinics or hospitals to get to the metropolitan area to work. So I know that over the years, lots of different organizations have started and stopped with data collection on different professions. Where are we?
Yeah, and for those of you who don't follow this issue, Missouri's been woefully deficient in knowledge about our workforce. It really has, no matter how you look at it. And so those of us in health policy who've been interested in this issue for a very long time are excited that we might get something better sometime in the future. But do you want to speak to that, Mary?
Yes, and I would echo your concerns. It's been a concern of the Hospital Association for a number of years. But we have collected hospital data, which obviously is only a fraction of the healthcare workforce. We've collected that for about 10 years. But there is, the Missouri Department of Health has begun a program, and Chris alluded to it, and you actually had the full name of it, but it's called Mo Health Works. And they are populating that with data from the license boards, the licensure boards, and they've begun with about 4 professions to begin with, but they've loaded the basic publicly available data. The problem is that we need to have individuals go in and complete census information on that. And MHA has been working with the Missouri Foundation for Health and the Greater Kansas City Healthcare Foundation to see what we can do to help move that process along. But they have really made significant progress. We've been very pleased with what we've seen because it's been a difficult issue to get around. So we have high hopes that within hopefully the next year or so, you'll start to see people go in and populate their census information, which would get to where they live, types of degrees, what types of specialties they have for all licensed health professionals, but we still have a long way to go.
And I would say it needs to also ask them where they practice, not just where they live, but where do they practice, where are their outreach clinics, where do they do telemedicine, to get a real complex, comprehensive view of the care that's available in different areas. So, okay, last question. Rebecca.
Hi, Rebecca McClanahan, Executive Director of Missouri Healthcare for All, and also brand new President of the Missouri Nurses Association.
Oh, didn't know that.
But I really ask this question as a former legislator. I've been busy the last few years. Is why we are not collecting this data, or why we're not getting ready to collect it at the point of relicensure. And I was approached very early on when I was in the legislature to work on legislation enabling that to occur, and that legislation passed that allows all licensing boards to collect additional data, but I haven't seen any movement on that issue. Are we ready to do that? Are we in fact going to collect that kind of detail at relicensure? And if we're not, why? Why are we not doing it then?
It's a really long story. It really is a really long story. Go ahead.
So it involves lack of funding for the state to make this possible. The really sad part about this is that one of the largest barriers was old software code that no one knew how to fix and change over the years, and so. But they've done that now. We're about ready to collect it, but we're going to need participation not only from the practice boards but also from the professional organizations to truly get all of this information collected and available. So there is my impression, my naive and uninformed impression is that we have a start to this, and it's on a really good start compared to where we were even 3 years ago. We still have a long way to go, but it's going to. We have a little time too because we have shortages in almost all health professions areas. So it doesn't really matter what we increase right now. We can increase as much as we want, but within the next 10 years, we may be in trouble if we overproduce in some areas and others. So it really is critical that we get this information obtained.
I actually provide less information to the State Board of Nursing now than I did just a very few years ago. I used to answer those questions. Even since I have renewed my license online, initially I provided more information, and now the last time I renewed, I was asked nothing. Mm-hmm. So there's a problem here in that even some of that data collection has dropped off, and we need to ramp it up.
Well,
Thank you.
and I think to get to that, there are restrictions in what the licensing boards can require, and most of that in the past was voluntary, but I think that the professionals didn't realize that it was voluntary because it seemed sort of seamless. And that's where we would like to see things move forward with the licensure boards now, as to how do we make that a seamless thing. But we've also got to create a sense of urgency among our healthcare professionals and an incentive for them to go in and complete that information. They need to understand why it's important. So we have a lot of work to do.
Do it before I push the submit button. I have to fill it out, and I have to opt out. Don't make me opt in, make me opt out before I push the submit button. That's my call.
Okay, do we know is lunch ready? Do we know? Okay, can you find out? Okay. Maybe one more question? Right here in the front.
Hi, Mike Cita with Tiger Institute for Health Innovation. One of the themes that I think we keep hearing today is that healthcare costs continue to rise, and our ability to continue paying for those just isn't going to be there in the future. And it seems to be a similar theme when we talk about the healthcare workforce. The demand is ever increasing, but the funding's not going to be there to pay for the additional training. So what are some ways in which we're preparing to handle that and deal with it?
Yeah, so that was about workforce. Oh, you guys all heard that. So, all throughout, for example, graduate medical education, everybody's sort of scrambling right now. I was just recently, I'm a dermatologist. I'm an EVIL specialist, right? And we were just in Washington a couple weeks ago talking about this, and there's a lot of people just sort of scratching their heads about how to get this done. What we don't want is to evolve to a situation where only people who have a lot of money become doctors, right? So a lot of people, even when we were in Washington 10 years ago, there were still people talking, they called it an all-payer fund, but there's people now talking about, why does Medicare pay for, why does the federal government fund all of graduate medical education when other folks benefit from it, like the payers, like the insurance companies, and so there's sort of a broadened conversation going on right now about how to really do that. Did you want to say anything? Were you going to say something? No?
I would only add, my students are going to roll their eyes when I say this, that for those of us that, or those of you that aren't health policy wonks, the issue of spending and payment and quality is an interesting one, and it's difficult to understand. So just yesterday, Ezekiel Emanuel, the well-known healthcare economist, and brother Rahm Emanuel, the mayor of New York and former chief of staff, started a series of articles. I'm sorry, I keep saying that, Chicago. Started a series of articles in the New York Times about that issue. So if it's of interest to you, he's got the bona fides to really talk about those issues and to do it in an understandable way. So I would recommend all of us start to read that kind of press. And so Emanuel in the New York Times over the next several weeks is going to do a series on those issues.
Okay. One last question.
Thanks, Chris. I'm going to put on my nursing hat for a minute. I work at the Sinclair School of Nursing. I teach community health. And I was really intrigued, Susan, by your comments about training nurses to be in home health, because we don't do that. We have the med-surg side, where it's all geared towards hospital nursing, floor nursing, ICUs, emergency rooms. And then the community health program is aligned with the public health system very closely, which has very purposefully gotten out of the business of direct patient care because that makes sense. We don't want people to have to make an extra trip to the health department to get their kids immunized. We want the pediatricians to do it. We want to make sure the pediatricians know what they're doing and they have good immunization rates, and if they don't, public health is there to assure that they're going to improve. So it's not, if that's what we need to prepare for, my question is, where in the curriculum should we put that? And we have really innovative faculty at the School of Nursing, and we're ready to respond to what the future needs are. I'm just wanting to put that out there.
and I'm going to say this not just for the nursing educators in the audience, but I think for everyone who educates health professionals, you know, we have a new day and we have opportunity to do things differently. And those of us who are faculty need to think about how we can break the mold. You know, I told you I was in D.C. last week talking with the Dean's Group, and they essentially said the same thing you did. Well, there isn't anybody out there that does this. Where are we going to put the students? We have to get creative, and let me give you a few examples of what I've done with my program. I coordinate the Women's Health Nurse Practitioner Program at UM St. Louis. A couple of the things that I've done, I used to take the students with me before I turned them loose in their clinicals with their preceptors. I used to take them all for a day with me at the county health department. And we noticed a lot of the prenatal patients weren't showing up for their visits because, you know, this was a high-risk population. So I took the students for 2 days, and on one day they did prenatal care visits in the office, you know, traditional prenatal care visits, and then on Fridays we went and did prenatal care visits in the home for those high-risk patients. There was nobody doing that. It was a way to get that experience to them, for them to see there's something that happens before and after they hit the office. We do another project, again with the Women's Health Nurse Practitioner students, where they do an assessment during one semester, and the next semester they do a community-based intervention with their populations to do that. So I think as faculty, we need to start looking at where we can integrate these ideas into the programs that we're currently teaching, and rather than looking for a place where it's being done, charge our students with becoming innovative in searching out ways to leverage those community resources.